So that's the other way.
I think it was up there last time. It was the last show up there.
It is 10:08 at WPSL 1590, talking the Treasure Coast, and live from the 81st floor, the penthouse suite of Florida Orthopedic Specialists. Dr. Joe Wiersbecki and Dr. Ed Southern. Good morning, docs.
Hey, good morning, Greg.
Good morning, Greg. Good morning, everybody.
How are you?
Very good, thanks. Yeah, we're both coming to you live from our walk-in clinic in Stuart, Florida, down on Indian Street and Willoughby. Number for Florida Orthopedic Specialists is 772-335-4770, 772-335-4770. And of course, if you want to call us live on Bone Talk this morning, 340-1590. We'll take your orthopedic questions, general medicine questions. I think we got to talk a little bit more general medicine too. Like, you know, we're always talking orthopedics, but there's so many parts of general medicine that you and I spent so many years in that contribute that I think we fun to mix in.
No, absolutely. Because people have questions, you know, it's everybody knows their friend Dr. Google. Everybody has a friend that's had something happen to them now. Obviously, a little limited insofar as how much. You have a little more primary care training than I do, obviously, but definitely something to talk about because some people, this is their only access to physicians. I can't tell you the countless number of patients. That's something to actually talk about. Primary care for men, primary care for women. I see countless patients, especially since I'm taking ER call at the two facilities, both Jupiter and St. Lucie, that they don't have a medical doctor. They have an injury that needs an operation. They have an injury that needs to be addressed, surgically, and they don't have the means to get a medical clearance, and they're in their 50s or 60s even sometimes.
And so many people out there, they're using the urgent cares or the ERs as their primary care doctor,
Right.
which is just not how the medical system is designed, and it's not what's best and most efficient for you and your healthcare.
Right.
The ER, those doctors aren't up to date on colon cancer screening, mammographies, what annual blood work should be ordered, the cholesterol management, gout, proper counseling for safety measures and things that you're supposed to be looking out for in that particular age group and risk factors. And so many people, I'm sure it happens to you, they come in to see you and they say, well, doc, just order the blood work. The blood work they're going to order.
Right.
Well, yeah, maybe we know 90% of it, of the blood work, but there's so much more to a preventative visit than just looking up on an app or a website or what we think the blood work is. And and it's your health. It's pretty important. So I don't get the other access issues and why more people aren't taking advantage of the primary care doctors. I do know that the primary care doctors are busy and you do have to wait your turn in line, and that can be 3 months, 6 months. But it is what it is. That's our system, and that's just how busy the primary doctors are. And you just got to get your turn in line.
Right. Yeah. And I definitely think COVID threw it off. There were a lot of docs that were only doing televisits, a lot of docs that shut their offices down. At least that's what I'm hearing is the consensus of a lot of the people. Mm-hmm. But at the same time, I have a 60-plus-year-old patient that has an arm fracture, has a lot of comorbidities. Like you just said, she's on medication. She's a very, very rigorous smoker. No medical doctor. I get patients all the time. I'm sure you do probably more than I do because you have more of that primary care type, global role as far as treatment.
Yeah.
They want you to refill their blood pressure meds, or they're this med, or they're that med, and it's, I'm not going to be responsible for polypharmacy. I'm not going to be the one drawing your blood work to make sure your cholesterol medication is working, or your antihypertensive medication is not raising your kidney affecting your kidney function. It's really important. So, like you said, preventative health. We talk about preventative health in orthopedics all the time: weight loss, diet, exercise, lifting weights, various shoe wear changes, so forth. It's just the same in every specialty.
And I get it. A lot of people, you're going to go to the primary doctor. They're going to give you a once over, and they're going to say, you're fine. They're going to give you a couple words. They're going to say the blood work is good, and hopefully that's the case for you. But it doesn't always go that smooth. And there could be something very simple, very correctable that if you don't address it on the early side, it is a much bigger problem, headache for you to deal with, 10 years, 20 years down the road, whether it's a cholesterol problem, a gout issue, maybe it's a blood work problem. A lot of people are fatigued and feeling low energy. Maybe you have an iron deficiency anemia versus a B12 deficiency that if you were correcting on the front end, you could have had years and years of increased energy and increased quality of life. And these are just some simple things that are coming to mind right now. I mean, there's a list of probably 100 things that if I sat down and thought about it, a list of correctable things that would massively change your life. And again, hopefully it's not you, but if it is, how different could your life be if this was discovered on the early end? Yeah.
I also think the advent and the availability of PPOs and various insurance plans where you can go directly into a specialist's office and bypass the primary care physician, the family medicine doctor, and so forth has been a huge detriment.
It's been good, but also bad. It's been nice that you don't have to go to your primary doctor when you need that referral, correct. But at the same time, like it's taking out that person who's an important part of your overall medical health.
I think we underappreciate primary care physicians. I mean, they really should be the quarterback of your medical care. They can save a lot of time, a lot of effort, a lot of searching. I mean, I could tell you, down in Jupiter area, because of access issues, the whole idea of the whole concierge practice is taking off. There's several concierge practices down there, and you get direct access to the patient, direct access to the physician. It's because so many doctors are doing that model, the cost is not as astronomical as people had once thought. Now, yes, not everybody can do concierge medicine, but if you think about it from the standpoint, a lot of these people in today's insurance market are dipping in their own pocket for exorbitant amount of money, north of $10,000 sometimes. If you do a concierge practice and it costs you $7,500 to have all access to the physician at your one-time fee all year long, it's not such a bad deal if you think about it.
I mean, think about what other people are doing to get their medical treatment how they want it, personally tailored to them, in a concierge type way. They're going to other countries. They're doing their own lab work at whatever clinic here. So they're paying so much money out of pocket. They want to know, do I have a COVID antibody? And they don't want to deal with the insurance. And so they go to the specific clinic and have their blood drawn, and they pay so much additional money. So it's kind of funny just in how the insurance companies limit certain things. And so people are just going around their insurance company altogether for some services. I don't know, the concierge medicine makes sense for a lot of people. They want easy access to care.
Right. And like I said, it's for people that, are having roadblocks to care. They can't access primary care physicians.
I ran into something this week that, I've been blessed with some real good health, and I'm going to have a simple cataract thing done. And, but, I have to make a trip to my primary doctor first. They need to know, before they do the surgery, whether I've seen my primary doc and am okay for the anesthesia, even though it's like a mild anesthesia, they said. So, yeah. That's very interesting.
And some of these trips to the primary doctor, you fall and break your wrist and you need medical clearance. And I don't wish this on anyone, but sometimes just by that lucky event of you breaking your wrist and having to have surgery, you go and check in with your primary doctor and they do their chest X-ray, and well, there's a mass in your lungs, and that would have never been discovered had this event not happened and had you not got medical clearance. Or you go and you have to get an EKG as part of your workup, and you see, oh, I got atrial fibrillation that I wasn't feeling. They may have not have felt it for 10 years, and the original event could have been a stroke that the atrial fibrillation made them had. So for some people, who aren't seeing their primary doctor, it's good that there's this part of the medical system forcing it to do so. And if you didn't do that, then the person gets anesthesia and they have a major, let's say that they had a lung mass, a lung cancer, and you get anesthesia without the medical clearance. well, then they get a blood clot, they get a stroke or a heart attack because they have an undiagnosed cancer that puts them at risk for clotting.
Right.
So, I mean, there's reasons for all this, and yeah.
I got a question for you. Is there a certain age where you guys might recommend that somebody, aside from primary care, might get a heart doctor involved as well?
So that, I mean, that goes back to what we were talking about before with seeking out specialists, sometimes unnecessarily. You know, it's one thing to be able to walk into the orthopedics office because your foot's facing the opposite direction when you fell off your ladder, and you think, maybe I should go to the orthopedics.
Primary doctor probably couldn't help me with that one. Yeah.
Most patients don't need to see a cardiologist.
You could go your whole life and never need a cardiologist.
Right. Yeah. So it's
okay.
You know, there's certain screenings that you need. Everybody, once you hit a certain age, and I think they just lowered the age again to 40 something, you know, probably needs to see a GI doctor and have a colonoscopy. Most certainly by the time you're 50, but I think they just lowered it to 40. I think they 40. Yeah.
And again, this isn't our wheelhouse, which is why you go to a primary doctor. I mean, there's reasons why they lowered the age of the colonoscopy screening to, let's call it 40, so we know.
Yeah. I know it used to be 50 or 40 if you had a first degree family history of colon cancer. Now they supposedly lowered it again. Again, like Dr. Becky said, talk to your primary care doctor about it. You will, but you're probably not going to have to see a cardiologist, probably not going to have to see a urologist. You're probably not going to have to see a pulmonologist. But you know, there are certain specialties that you will inevitably cross paths with. And it goes back into that preventative medicine, that screening model. Do you need screening to prevent or catch certain disease processes? I think every woman should have an OB/GYN, or at least a family practice physician who will focus on the GYN aspect of that patient's health and refer out to somebody if need be.
Yeah. After a certain age, Greg, you know, all people are getting an EKG. And I don't know what it is. Maybe it's 50 years old. You know, when you go in for your annual visit with the primary doctor, they're going to check an EKG. They're going to check your blood pressure and your labs and your pulse. And if there is something that is showing signs that you're at an increased risk for heart problems, they're going to get them involved. But hopefully that looks good. There's no changes on the EKG or concerning things on the blood work. And you just continue to monitor. But yeah, most people will eventually see a cardiologist when there are those risk factors, because as you get wear and tear on the heart and the vessels, you know, most people are going to develop blood pressure as they get older.
I got a question. Of course, the big story on NBC Nightly News was life expectancy, that it has gone down for a second straight year in the U.S. In your opinions, is a lot of that the pandemic, being closed down in a pandemic? I mean, how do you feel about that?
The numbers, you know, and people who may have died, you know, 2 years, 10 years later, you know, and yeah, those numbers COVID had to have affected those numbers. Yeah.
I mean, it's hard to say. I'm sure they skewed them. The question, I didn't see the study. Did they correct for that? Because you know, you could correct for the increased mortality with certain disease processes.
Yeah.
But I think we're sugarcoating it. We're fat and unhealthy. I mean, let's be honest with one another. You know, it's.
Hey,
no, I mean,
tell
look
us what you really think.
Yeah, I mean, for those of you that are watching, I mean, I'm overweight. I need to trim down. I mean, sitting next to Dr. Becky, it's, you know what I mean. I look bigger than I thought I did. So it's.
But I mean, the life expectancy, you know, and again, I'm going to assume it's a skewed number study, because what you may also hear is that the maximum age, you know, that humans are reaching is going up. And there's a lot of longevity medicine specialists who believe that we will see the 150-year-old human, you know, in our lifetime. You know, that person is already out there and older than me, older than Dr. Southern. I'm not sure if they're older than Greg. Yeah.
No, I don't think anybody is. Oh,
but it's happening. And so because of longevity medicine and what we know about, you know, tobacco and exposure to chemicals and sugar and alcohol, and people who are doing right and getting the right medical care, the maximum, what would you call it, maximum life expectancy of the human is increasing. And so if everyone were to follow some of these guidelines that we know are healthy behaviors and seeing their doctor, yeah, they're going to get the most out of their body.
Makes perfect sense.
Yeah.
It's what we're starting to see, I think, orthopedically, even with some of these real young football players. I mean, boy, blown ACLs left and right in the NFL. It's like, man, that preseason was rough.
Yeah. And they've looked at this for a very long time. They've gone back and forth, and it is an ever-changing discussion. Surfaces, play surfaces, the different kind of turf surfaces, the grass surfaces. Is AstroTurf better? Is field turf better? Is chrome rubber better? Is the cork better? Is it better to just play on natural grass? So on and so forth. What I'll tell you is that all the studies that we're going to do, there's a lot of things that are being overlooked, and that thing that's being overlooked is the maximum tensional forces that the knee can withstand. You would be astonished if you looked at true newtons, which is the measure of force in physics, the amount of force that the ACL, PCL, MCL, LCL can withstand before it ruptures. It's only a couple of hundred. It's well below 1,000 newtons of force that where the ACL, if it's maximally stretched before it pops. It's the musculature around the knee that really keeps the knee ligaments from tearing. Now, the corollary to that is as we get, and you've seen it in your lifetime, and you played professional baseball. I always laugh when they're the natural athlete. You don't want to throw people under the bus, but to Dr. Worsbecky's point, yes, people are eating better. They're cleaner living. They're the Tom Brady approach. And then of course there's the Mark McGwire approach. How
would you describe that, the Mark McGwire approach?
I don't know, supplemented. Yeah, supplemented. So you know what I mean?
Is that what you call him?
That's what I'm coming.
Not to his face. Well, maybe now he's a little older, so maybe now, but not then. So even probably not now either.
No, believe me. When Mark was in college at San Diego State, it looked like a tree.
Right.
It's yeah.
And he's just the first one that came to mind, but I mean, it's good. He's one of the most prevalent in the news for whatever reason, and it's very anecdotal. It's funny because people give the baseball players a hard time all the time with supplemented play, but when's the last time you ever heard somebody talk about an NFL player that's supplemented? Pretty much all of them.
Yeah.
So, but no one talks about it, right? So it's one of these things. So now you've created a situation where you're incredibly changing the forces across a knee. Your muscle, your tendons and ligaments don't get stronger with supplementation, with steroid use and anabolics and so on and so forth. Your muscles do. So you increase the force, you increase the tension. Now, interestingly enough, you actually decrease the quality of the muscle. The muscle gets softer. I've had a couple of patients that use, it's very hard to fix muscle when it tears because it's very, very soft and friable. But again, you're now taking a body that's designed to protect itself against 1,000 newtons of force, and you're creating 3,000 newtons of force. And I'm just throwing numbers out there just to give you an example. And you're going to get injured. And now you put field turf situation changes. Now you have guys that are putting 3,000 newtons of force across your body, contacting you. It's just a recipe for a disaster.
Yeah,
it's interesting. Each joint is so beautifully designed for its specific purpose. Our knee joint, our shoulder joint, the range of motion that it has, and the stability, the dynamic forces are so beautifully designed. Our hip, for example, nothing at all like our shoulder and our knee. And I mean, our hands, we develop so many problems because we have this beautiful thumb that goes through such a wide range of motion that a lot of people get arthritis at the base of their thumb. And so, we have these beautifully designed joints, and when you push them to the extreme, there's going to be breaking points. And why is it ACLs and rotator cuffs It's part just because of how the joint is built so that we can function in this incredibly complex way. And then when you push it to the extreme, you're going to have problems. And these are some of the breaking points just because of what we ask of it.
By the way, thank you very much for complimenting me and being an athlete. I know I wasn't. I was a pitcher. Lou from Fort Pierce is with you. Lou, you're on with the docs. Go.
Seems to me that these kids these days have awful strong thumbs.
These kids these days have awful strong thumb. Yeah, on their phones.
Same thing with motorcycles.
Yeah, same thing with motorcycles. We can barely hear you, Lou.
Yeah, strong thumbs.
Get off speaker.
Oh, there you go. All the difference in the world. Go ahead. You're on with the docs.
You guys ever ride an old motorcycle?
Docs, did you ever ride an old motorcycle?
What's considered an old motorcycle? I mean,
I've never been on a motorcycle. Yep, after rotations in the emergency department, yep, and seeing some of the bad accidents, I've never been on one, and I never will. No.
I mean, I had pictures of me and my grandfather's Red Wing from back in the early 80s, which is a Honda for those people that, or Goldwing, I think it was one of those two. My uncle had a Fat Boy for a while, which was nice, but I don't know if you're talking about old motorcycle, but is there I mean, motorcycle then, motorcycle now, it's two wheels, goes fast, has handlebars. Is there a difference?
What about that?
I'm talking about the way of starting the motorcycle. Now they got to use their thumb and they push a button. But I have 3 older bikes that require that you kick them. And in doing so, I have really put a strain on my right leg, mostly right on top of my right knee, like right before that big bone is sticks out there. It hurts like hell. What can I do about it?
I see.
Yeah, and so, that front of the knee pain that you're getting with that position of the motorcycle, to me, it sounds, and what I see with a lot of people who ride motorcycles is that you're in that prolonged position for such a long period of time. And when your knee is bent like that, your kneecap is driven right back into your femur. And that puts a lot of excessive prolonged pressure against that cartilage. And that cartilage can get weak and inflamed, and it doesn't like all those forces up against it. So, you got to try and avoid those prolonged positions, and kind of move it around, work it out. And especially the prolonged flexion, where your heel is even closer to your butt. That can really put a lot of undue force and tension on the kneecap and the cartilage. And so it's not a great position.
And I don't know if the kickstart is actually the
source,
source of your problem, or it's just irritating a problem, as Dr. Worsbecky said, that you probably have a little cartilaginous wear back there. The patellofemoral joint is a pretty common area for people to get early arthritis. It also tends to be the one compartment in the knee that it's pretty much the most tolerated, at least to a degree. I think most patients with PF arthritis are not really bothered by it. But it's hard to say. I mean, and that might be one of those things that, again, you get back to have your primary care doctor take a look. And if it really is an issue, then they will send you to your appropriate orthopedist. Or if it really is an issue, you can come on down and we'll take a look at it for you.
Yeah. But definitely the first thing is you're trying to work around it.
All right.
Thank you. Be careful with that position.
Thanks for calling. Give them a call, Lou. They can, they'll fix up that leg. That's very interesting about the pressure, and it stands to reason because they can't really move their knees at all while they're riding. So there'd be constant pressure just from the roadway.
In one specific position, certain parts of the cartilage, they're just pushing up against certain others. You're not moving it around. You're not giving it a breath. It's just constant pressure. How would you like it if you were just constantly like maybe on your knuckles, for like a plank position for a while? Your body's not going to like it that all that tissue is never getting a break. So that's one way that I like to think about it. Yeah.
Yeah. Well, it's interesting. 340-1590. If there's anybody else out there that has a question, feel free. Give us a buzz.
Just gave my wife another reason to not let me buy a motorcycle.
Oh, yeah. If she's listening, you're toast, pal.
Yeah.
You're done.
I almost had her too. Now forget it. Now I'm gonna have bad knees too.
Oh my. Well, and Dr. Joe, there on the other side, you treated a lot of those injuries, and I remember, you know, of course, Carol was a reporter at NBC in LA, and she did a story. It was way east, not quite to Palm Springs, but there is a huge rehab hospital out there for severe motorcycle injuries or head injuries in general, but mostly 90% of them are motorcycle. And she said, boy, was that an awakening. It really was, where you realize what can happen in a high-speed accident.
Yeah. I mean, you know, take someone, you know, young like ourselves here. You know, what is most likely to significantly affect my life going forward right now? It's an accident. You know, if it's you know, someone who's not in the medical field, you know, maybe they accidentally take too much medication that they're not supposed to. They get in a motor vehicle accident, they get in a motorcycle accident. You know, these are some of the biggest risks out there, you know, for younger people. And yes, those kind of change as you get older, but you're at significantly more risk for major health problems, you know, being on a motorcycle than you are minimally being in a car. So you forget just how dangerous cars are, and we take it for granted because most of the time nothing happens. But you know, the more you text on your phone while you're driving or have distracted driving, maybe you're sleep deprived or on a medication that you shouldn't be taking while you drive, your risk increases. So we like to minimize risk, and that's a lot of what we do in medicine and in orthopedics. It's looking at numbers. What's your probability of good versus bad? You know, you come in with a shoulder problem. All right, we're calculating this is your odds of having a problem during surgery, or by putting you on this medication, you know, what's likely to affect you and get you to where you want to be. So it's a lot of risk calculation.
Now, for you, again, as both of you have stressed over the years, body mass index, and Dr. Ed, you mentioned we're getting a little heavier in this society. Body mass index really, especially for you guys, is a key for both the knees and the hips.
Well, I'll tell you, there's a lot of literature, even in my early residency. BMI, or body mass index, actually will negate your access to surgical intervention from a joint replacement perspective. Mm-hmm. And I will tell you that the more and more regulated patients get insofar as insurance, it is going to come the day, probably in our lifetime, that if your BMI exceeds the national standard or what's become accepted and safe practice, they're just not going to pay for your joint.
I can definitely see that. You're right.
It's definitely going to happen, because I mean, there's strong literature out of NYU, Hospital for Joint Diseases, that look at BMI over 40 as having a unsatisfactorily high risk for complications after knee and hip arthroplasty. Infection, dislocation, fracture, polyethylene wear, loosening of the hardware, so on and so forth. And these are just in regular people. So now I take the BMI of 40, who's probably a hypertensive, probably a diabetic. On top of all of that, their complication rate goes even higher. So, I mean, you're going to see it. I mean, it's unfortunately everything in society for the most part, and you know, there are exceptions that don't. It comes down to the almighty dollar. I mean, it is capitalistic society, whether you like it or not. And if I have a pot of money that I'm going to redistribute to people, and I have a group of people that there's a 90% chance that I'm going to be burning that money and basically throwing it in the garbage, or there's a 20% chance that I'm going to spend that money, and those people are going to benefit and utilize my funds, even though they're the ones that gave me the funds to begin with. I'm not going to redistribute that wealth accordingly. So my point is, insurance companies are going to say, oh, you're diabetic. Okay. But your BMI is this, your A1C is this, and you've had a year to get this down, no surgery, so on and so forth. I have to be quite honest with you, I'm probably being the bad cop in this, because again, I'm guilty of it myself right now, although I'm not, unfortunately, I don't have those problems. But if I don't do something differently, I'm going to have those problems. We have become too complacent in this society where we expect everything to be given to us, and we don't want to do anything in return to get it. So how dare you tell me to not be 300 pounds? How dare you tell me to not eat McDonald's every day? How dare you tell me that I have to go to the gym? No one's really telling you that. You don't have to do any of those things. These are just suggestions. There's time-honored science that has looked at this and said, you know what? And we're learning more and more every day. I mean, look, case in point, we talked about this a few weeks ago. Look at the number of graduating high school students that couldn't pass a military physical if their life depended on it. Yeah. The military enrollment rate is not below 40% only because of people just not wanting to serve. It's below, of that 40%, there's an exorbitantly high percentage of those people that actually can't pass the physical. So exclude the 60 that don't even want to do it. Of the 40, there's a high percentage that don't qualify for various reasons, because physical activity is no longer becoming a priority in our young age. We're not teaching in the schools. We're making physical education
elective?
Not even elective. I'm thinking of elective, but it's non-mandatory. It's it's being taken out of your curriculum altogether across the board. It's not gym class. It's physical education. Right?
Yeah, and replaced with computer coding or something like
Correct.
that. Yeah.
Which is important too. But even the computer coder has to get up and walk away from his or her desk every once in a while, instead of designing a newer, better keyboard for carpal tunnel syndrome, or a newer, better chair, so you don't get degenerative joint disease and so on and so forth. Just, you know what I mean? It's just, and then when you get to that point where you made lifestyle recommendation changes, change this, change that, change the other thing, and now you're 350 pounds, you're 55 years old, you can't walk because you have degenerative arthritis of your knees, I need surgery. Sorry. I mean, you want to help that patient, but the goal is to try to help that patient 200 pounds ago.
Yes.
Maybe not even have the degenerative joint disease. I mean, degenerative joint disease, arthritis, is a genetic disorder. There is a genetic linkage to arthritis. I've seen patients that are obese and overweight. They don't have arthritis. I've seen patients that have a BMI of 25 that have terrible arthritis, and not rheumatoid. We're talking about osteoarthritis.
Sure.
So it's, there is a huge genetic component to it, but more so you see it in the alternative. There are ways to mitigate those factors, and things like exercise and weight loss. And I've talked about this excessively. The American Academy of Orthopedic Surgeons, the level 1 evidence in preventing arthritic changes or how to treat arthritis in the knee, exercise and weight loss.
Yep.
Number 1.
Take it to the other conditions, heart disease, Alzheimer's disease, dementia. The number one thing that you can do to prevent Alzheimer's disease or just dementia as a whole is exercise. That is by far the number one variable. It's not controlling your diabetes. It's not controlling blood pressure. It's exercise. It is beyond a fact. It is as fact as we know in medicine, just the good benefits that come from exercise.
Wow. Dan is with you from Port St. Lucie. Dan, go ahead. You're on with the doctors.
Okay. Good morning. I have
morning.
a question that really is more directed for Greg than the doc. I listen to the shows very often, and like the show this morning, the doctors come through kind of like they're in an echo chamber. And
whoops.
Yet when Greg, when you speak, it comes through very, very clearly.
Okay, that's the mastery, Dan. That's the mastery of Zoom. It is what actually I use it too with Indian River State College basketball. But yeah,
is that better?
That's what happens when you go. The web has a lot to do with it. Yeah, and so yeah, there's all sorts of machinations there, but we get it. Believe me, we get it. And somehow, some way, the folks at Zoom, unless they file for bankruptcy by this afternoon, will eventually help with that as well.
So Greg, are we sounding echoey? Is that what what I heard.
Yeah, well, you're in a lively room, right? You don't have any carpeting in the room, right?
No.
Yeah, well, that's we had that issue with our attorney who does a show from his house, and he doesn't have carpeting in the room he does, and so it's lively, so yeah, that's you're in an office,
Right. I mean, it could be our setup too, our microphone, the way we are, the fact that we're both here today in the same office. We're sitting a little further back so you can catch us both on the screen. So we apologize. I hope the gist of what we're trying to say is coming across.
Oh yeah, no, it's
probably not coming across as clear as we'd love it to.
I think down the line, when they start making affordable lavalier mics and stuff that you guys can just wear, that would work. That would help things out. Or like what I use, sports headset. But yeah, it's all in the technology. It's getting there, and it'll get better and better as we move on.
Nice.
Yeah. Thanks for calling, Dan. And I still go back to Louis, and I think about motorcycle riders, and yeah, they're in that one position. It could be for hundreds of miles.
Another thing that I think about with the motorcycle riders is, and you probably see this more, Dr. Southern, the different handlebar positions. We know how bad it is, to do a lot of overhead shoulder activity. And those guys that are, I don't know what those handlebars are called, that are really up high, man, that's got to be really tough on their shoulders. I don't get that position. That's got to be a major irritant for people's shoulder bursitis and rotator cuff when they have their arms up there like that.
To be honest with you, I don't know of any literature that's looked at that, but knowing motorcycle riders, those T-bars, that they swear that they're the most comfortable way to ride a bike.
Really?
I mean, if you're going long distances, if you look at a Harley Fat Boy or a low rider where you're sitting a little, lower to the chair, the wheelbase is a little lower to the ground. I don't really know the motorcycles that well, so all the true motorcycle diehards are probably cursing at me right now. But it is a much more comfortable position for distance riding than being hunched over a Ducati or a racing bike.
Yeah.
And most people don't take their racing bike across country, but when you see the biker groups that are going long distance, they're the ones on the highways. They're the ones that are even the weekend warriors that they get together and they do the long ride, which might just be 95 or A1A or US1. When you're going for miles and miles and miles, the handlebar position, if you looked at it and we studied it, it's probably very ergonomically designed with intention. Right? There's some coolness to it.
Yeah,
that's fair. Well, for the first time in 15 years of this show, Bone Talk Show, this is the first time we've talked motorcycles. So
I will tell you, the one thing that I'm amazed, and the Martin County folks are probably going to hate this because that's the beauty of Martin County, is there's a lot of freedoms here, is helmets. I don't understand, me being originally from New York, 4 or 5 years ago, in an overregulated state with the daddy looking at you and so forth. As a physician, as a surgeon, as a guy that went through 3 years as a general surgeon working in the busiest trauma center in New York, seeing people ride around on a motorcycle without a helmet, as cool as it looks, as wind in the hair as it looks, thinking about that guy, on a Fat Boy with a great pair of sunglasses, leather, vest and whatnot. I mean, looks really, really cool. But the amount of head traumas that can be prevented by a simple item like wearing a helmet. I mean, if you hit your head against a hard surface at 40 miles an hour, you're pretty much done for if you don't have a helmet on.
We see it all the time in our clinic. Someone will come in with a shoulder separation because they were on their bicycle and, they were going 30 miles an hour and it crashed. And, they cracked their helmet open and, they dislocated their shoulder. I mean, that helmet saved their life. And I wish more people would hear those stories. Wear a properly fitted helmet that's properly secured. I remember growing up, we had to wear our helmets. And so, we'd throw it on top and it wouldn't be attached or anything. And so, we checked the box and we were fine. And luckily we were fine. But if it's not buckled up, you fall off your bike, your helmet falls off and it's basically no good anyways. So, and to bring you back to this area too, we don't have the best drivers here. Sometimes people aren't always watching where they're going, or maybe some people shouldn't be behind the wheel. And those bicyclists, those motorcycle people are at more risk because of the not so good drivers here. They're looking around, they're looking at the water or their phone, or maybe they're not seeing so good. Yep, I hope you're wearing your helmet. Yep.
I mean, I'm all for freedom of choice, and I'm in no way, shape, or form advocating that we create a law where motorcycle riders have to wear helmets. But as a surgeon, as a physician, talking about preventative ways that we can help mitigate injury and damage, I would love to see more people make the decision to wear them, simply because of what we're talking about. Yeah, and I get the counter argument. So, and I agree with that argument to some degree. If I'm doing 100 miles an hour on a highway and I get into an accident and I have a helmet on, I might be in a permanent vegetative state. At that point, I probably don't want a helmet on because I'd rather just be gone. Yeah. But those are not the vast majority of your accidents, because most people that get into motorcycle collisions or so forth are not on the highways. They're, like Dr. Becky said, they're on the local roadways where you're looking at your 30, 40, 50 mile an hour highways where somebody runs a red light, somebody just cuts you off. No one's looking out for the motorcycle rider. My uncle back in the day got his tibia crushed riding a motorcycle on Long Island. Woman just decided that he was in the lane that she wanted to be in, and he'd be damned. And off the motorcycle he went, into the guardrail he went. So basically his left leg was pinned between the car and the motorcycle. She stuck to the motorcycle long enough to crush his leg before they threw the bike to the right, and into the guardrail he went. So he survived, but his leg doesn't look like it's a great leg. He still has sinus tract infections from when things happen in his leg because it was an open tibia fracture. It's, these are real circumstances, real concerns. My brother, another guy, he grew up, motorcycles. There was a racetrack in New Jersey where you could take your racing bikes. So he had the, 1000R or R100, I believe it was. It was Kawasaki's bike. He decided to open it up. He grabbed the throttle a little bit too much. The whole bike kicked out from underneath him. He probably hit about 90 miles an hour. Boom, thing went by. He slid about 150 feet on the ground on his back. Had he not had a helmet on, didn't have a leather jacket on, I mean, the bike went, a good 500 to 600 feet, just ass over tea kettle, kept going. And he just slid on his back, on the back of his head. Now imagine sliding for 150 feet with your head contacting the ground every single time. Wow. At 90 miles an hour. It's there. I mean, there you go.
Oh, man.
No helmet. It's
Greg, in most of the sports players' contracts, are any of them even allowed to ride a motorcycle? Do you know? I'm guessing now most athletes just aren't allowed to own, ride at all a motorcycle, or there's kind of like an exclusion type clause, right? I think Big Ben Roethlisberger got in an accident when he wasn't supposed to be riding one. It like completely voided his contract. I forget.
Yeah, no, it's actually Mark Rogers is in Palm City. So Mark, if you're listening, give us a call about all of your clients who are in both pro football and Major League Baseball. That's a very good question. I remember, of course, this is back before either one of you were born, with San Diego Padres used to have a mandatory clause there. It was like when Dave Winfield started and Ozzie Smith, people like that, they couldn't drive a speedboat, a hydroplane on Mission Bay. And actually they tried to get some of the Padre players to do, when they had the hydroplane races there, a charity race, but the team would not allow it at all. And then the same with motorcycles or race cars.
Yeah, I think it was the #1 overall pick in the NBA draft. It must have been like 10 years ago. Markelle Fultz, the point guard from Washington. They heard that he had a big interest in BMX riding, And so they specifically had it in his contract that he couldn't do this. And a lot of people will say that Markelle Fultz is one of the biggest busts in NBA. He's still trying to get his rhythm. And some people were very suspicious that he had a BMX accident, couldn't report it. And that's what developed his shoulder issue. And that's why his shot has never been right since, because it's one of the biggest mysteries for why this guy just all of a sudden lost his shot and the change in mechanics. And so, if they know that you have a big hobby in skydiving or bungee jumping, BMX riding, something that's really high risk for injuring yourself, and they have you for a lot of money and you're really important in their franchise, they're going to limit that. And it makes sense.
Yeah.
Oh yeah.
And there definitely is. There are clauses that you can't play pickup sports and whatnot, or they're not.
Yeah.
I mean, the thing that comes to mind is
basketball.
What was the movie that Wahlberg did with for the Philadelphia Eagles, Greg? Invincible. So remember, his buddies used to do the pickup game, and they used to play that mud football by the bar league, so to speak. And you remember Mark Wahlberg saying, I can't play. I'm on contract now. I mean, I'm sure that's real. I mean, would you know anything about that? Or is that legit?
Boy, Dr. Joe, you probably would know this player, this famous player, who was injured off season playing a pickup basketball game.
I think you're talking about the Bucks kicker, Connor Garth, something like that. Tore his Achilles playing.
Yeah,
playing a pickup game. Yep.
Yes.
Yep.
Yeah.
Yeah. It's kind of interesting the injuries that the athletes get themselves into off the field. There's some pretty ridiculous stories too. Like someone was JPP. Was one of the big ones. Injuries off the field. He had the firework accident and lost several fingers. Some of the athletes are playing around with knives that they are collecting and then accidentally stab themselves, or accidental guns being fired. It's unfortunate, but you're playing with fire.
Yeah, the famous one for me when I was in New York was Plaxico Burr shot himself in the leg.
Yes.
My buddy was actually on call that night. Could look it up, but the Giants player rolled into the ER at Cornell with a hole in his leg, and that was interesting.
Oh man. Oh brother. Yeah.
But I mean, it's we talk about this all the time, and it's we kind of get a little tangential, but it really goes to, from an orthopedic practice standpoint, the difference between the professional athlete and the average Joe, and even the average Joe who's an exceptional athlete is still not the professional athlete. Now maybe they could compete at that level, but it's the requirements of the professional athlete. It's how they're treated. It's the fact that they're essentially a commodity. They're somebody else's property, so to speak, for lack of a better term, at least contractually, that, there are certain things you can and can't do. That you have to understand that, I have to protect my body. My body is my temple. I have to be ready, because if I don't, I can't put food on my table. And, why does a professional athlete get an MRI on the sideline? And the patient that walks into the office with a shoulder pain, the first thing they ask for is an MRI. And so-and-so got one. I was watching the football game last night, or so-and-so got x-rays basically in the tent and got sent back out into the field. They put a brace on him and out he went. They put a club on him. It's just a totally different world, how we treat professional athletes' injuries. Sports medicine for the professional athlete is not sports medicine for most of the rest of us.
And you mentioned the professional athlete too, and you just think all of us, when we're young, we're invincible, nothing can hurt us. And you think about the mentality that someone has to have in order to become a professional athlete. Not only the genetic gifts, but that mentality to believe that you are the best, you are invincible, nothing can hurt you. They all have this. And unfortunately, sometimes that gets them into a bit of trouble, as they play with fireworks or throwing knives or doing whatever else they do, that mental state can get them in trouble. We have patients all the time, and they know they are their own worst enemy because they are 70 years old and they still think that they are 20 years old and that nothing can hurt them. And they end up in our office all the time because they overdo it, throwing their grandkids in the pool or trying to do a spinning slam dunk. Our minds can be our own worst enemy. And I think the biggest thing we can do, young or old, is really be aware of that. And it's tough.
And getting back, the other thing aside from that is starting from a very young age for the ones that, the less than 1% or the less than 0.1%, I think it is, that aren't headed towards professional sports, stay physically active, be healthy at a very young age, men and women, work out, lift weights, get your peak bone mass in your 20s while you still can. Get mobility training, get flexibility, get into yoga, strengthen your core, loosen up your posterior chains, your hamstrings and your low back, keep your shoulder girdles mobile. So when you get older, and nobody's going to tell the 70-year-old granddad not to throw your kid up in the pool. Most grandparents look forward to becoming grandparents. That's one of the biggest joys of their life. You want to be able to do those things. You're probably going to do those things, but be able to do them safely, protect yourself. So the 20-year-old that thinks they're invincible, the 18-year-old that thinks they're invincible, the 16-year-old, of which I have one at home, who thinks he's invincible, 40 comes up pretty darn quick, and then 60's next. So if you don't prepare yourself for the future where you want to do those things, in Florida, we now have full contact pickleball, for example. I mean, that's what we're doing now. People are playing these great sports. They're doing these things. Florida is such a great place. I love it down here, right? It's the 70-year-old in Florida is not the 70-year-old in Minnesota or Montana or North Dakota. Not that they're incapable of doing these things. It's a different mentality. It's just a more active lifestyle. This is a destination for people that they don't come here to die. They come here to live, I feel like. So you might as well prepare yourself at a very young age.
Yeah. Well, how do we get a hold of you, doctors?
Well, Dr. Southern and I, we're in our walk-in clinic in Stuart, Florida right now at the intersection of Willoughby and Indian Street. We also have our other clinic in Port St. Lucie, close to Walton Road and Highway 1. The telephone number for us, Florida Orthopedic Specialists, is 772-335-4770, 772-335-4770. So give us a call or listen next week.
All right. Sounds good. Well, you doctors be well and have a good week. Okay.
Thanks, Greg. You too.
You've been listening to Bone Talk now in its 16th year beginning. Wow. Hard to imagine right here on WPSL Port St. Lucie, talking the Treasure Coast, webcast of the world.